Thank you. Good morning. I want to welcome everyone to the Rena Schecter Memorial Lecture. I have a distinct pleasure to introduce my dear colleague, Dr. Pat Loehrer. Before I introduce the speaker, I do want to say a few words about this lectureship. As many of you may know, this lectureship has been in existence since 1996, established by Dr. Sam Schecter in honor of his late wife, Rena Schecter, who passed away from pancreatic cancer. And Rena was a force when she was there. She was a WashU alum throughout, from bachelor's to master's, and she spent a lot of time supporting many activities in the cancer, in the medical center. Dr. Sam Schecter was a physician for over 40 years and a World War II veteran, and also did a lot of work to support activities at WashU, including supporting mental health service. So these two played a major role in our medical center, and we are very grateful to them for the support. Over the years, we've invited really some of the leaders in the field who have really produced transformative changes in oncology. And if you go through the list on the back of the brochure, you will see some of the influential leaders who have shaped the field of oncology. To name a few: David Johnson, that Pat Loehrer is very familiar with, Tom Lynch, Charles Sawyers, and more recently Charles Rudin. So it is quite fitting that we have a fantastic, wonderful, great leader, Pat Loehrer, today to give this lectureship. And I do want to say a few words about Pat as a person. But before that, Pat Loehrer is the Joseph W. and Jackie J. Cusick Professor of Oncology and the Director of the Center for Global Oncology at the Indiana University. He also stepped down not long ago as a Director of the Indiana Cancer Center at IU. And he also led the efforts there to get a comprehensive status there when he was a leader. And prior to that, he was a leader for the Hem/Onc division there. And currently, he is leading this AMPATH global program in Kenya, and that has really produced transformative changes, including promoting cervical screening in over 50,000 individuals, and has really served a major cause, and that's his passion today, and we will hear about that. But prior to that, he was also quite instrumental. That's how I got to know him, as a founding leader for the Hoosier Oncology Group. Pat has a great sense of humor, so he named the group as HOG, H-O-G, Hoosier Oncology Group, and many of us got our teeth early on in our cancer research field as a member of HOG, and recently now it has become the Hoosier Cancer Network, Research Network. And Pat has published over 300 papers and has authored over 80 book chapters, and has been a recipient of several NCI grants. And despite accomplishing all these things, he's still very active, sees patients 2 days a week, travels around the globe to promote global oncology. And above all, I do want to say that Pat is one of the most compassionate human beings I've ever known. And I say this not to exaggerate the kind introductions we often give to speakers. It's the truth. And right from day one, when I was a young assistant professor, Pat took me under his wings and supported me, guided me. And he's a true, genuine person, a very compassionate physician, a great human being, something we all should strive to be. Pat, it's an honor to have you. Welcome to WashU.
Thanks for the incredibly kind introduction, and thanks for all of you for coming to the lecture today. I was told by the CME office yesterday that I needed to do a few things. So first I have to figure out how the button works. There we go. So I have no disclosures. I did want to start out, though, by talking a bit about what I could find about Dr. Schecter. And Dr. Schecter was a clinical assistant professor here at Washington University. And in the academic standards, we would think, you know, he was here for 40 years and all he got was an assistant professor. What kind of impact did he have here? Well, it's interesting that his He had 2 children that died of depression. I don't know the details of that, but he established a scholarship in honor of them. When his wife died of pancreatic cancer, he established this lectureship. And then just before he died, a few years before he died, he established the Samuel Schecter Professor of Medicine Award, which was given to this man, Gustav Schoenfeld. It's interesting, if you do a Google on Schecter, you can't even find a picture of him on Google, but you can find Gustav Schoenfeld. Now, Dr. Fraser probably knows Dr. Schoenfeld. He's a very interesting man. Back in the 1940s, he and his father happened to be imprisoned at Auschwitz. He was 10 years old at the time. His father was a physician, worked in a dispensary, and his son, who was 10, helped him through this. They managed to survive Auschwitz and then eventually emigrated with some help from family here to St. Louis. Well, when he came here to St. Louis, he was an intern underneath Dr. Schecter, and Dr. Schecter really embraced him and his son. A few years later, Gustav then graduated from a medical school and joined the faculty here. He was a renowned researcher in lipoproteins and cardiovascular disease, and 25 years ago was head of medicine here, where Dr. Fraser was. I think it was one of his last gifts that he could give, but Dr. Schecter ended up bestowing this to Dr. Schoenfeld as the first recipient of this award. The lesson for that to me is that you can make an impact in many different ways without having to be a full professor or distinguished professor. And today we honor the Schecter family and for all they have given to this university and for all they've given to others. All right, here's a quiz. This is where this is audience participation. Anybody know who these people are? Good for you. Okay, because you grew up with Lenny. And we'll go back to that in a minute. And who's the one on the right? Okay, well, we'll start with Lenny Bruce. So Lenny Bruce in 1966 was arrested for saying 9 dirty words. He was convicted and never had this conviction overturned until after he died in 2003. The fellow on the right is George Carlin, and that may be familiar to some other people. He was arrested in Milwaukee because he performed this performance called The 7 Words You Can Never Say on Television. I have to say that I suspect that every one of us in this room have used at least 6 of the 7 words sometime in your life, if not all of them. Eventually, they broadcast this on radio by mistake during the daytime. Someone was offended at this. It went to the Supreme Court and eventually came up with this ruling, the Carlin ruling. Well, 8 years ago, this is 2017, the CDC officials flagged 7 words and phrases, and here they are: diversity, entitlement, evidence-based, fetus, science-based, transgender, and vulnerable. And the result of this, and this was right at the end of the Obama administration before Trump took over, it turned out that 2/3 of these, there was 2/3 less use of these words in the in the grants that were subsequent. Well, now we go to today, and this is an article from a couple months ago from the Washington Post about the National Science Foundation and the words there. I'm not sure if you guys have seen this, but this is a list of some of the words now that are now going to be flagged in terms of looking at grants and other publications. In the bottom right corner, you can see there's a word there that I thought was interesting called women. I bring this up as well as these other flagged words by executive orders and state bills because this is new to me, and so in my talk today, I'm afraid that I may slip into using 1 or 2 of these words here, so I apologize in advance for this. I'm going to try my best not to do this, but I don't think I can say non-white, non-men very often as we talk about the people of Africa. So what I'd like to do today is just to give a brief view of the world. I'm going to talk a little bit about cancer then and now, cancer and the public health crisis, our work that we have been doing in Kenya and beyond, the AMPATH experiment. We'll talk a bit about pragmatic trials and partnerships, and then finally I'll just summarize with some ideas of where we might be going. So if we move first to cancer then now, it was In 1970, so I was, I don't know, in grade school, high school at that point in time, just to give you a sense of what it was like, cancer was not like it is today. The only curable cancer at the time was acute leukemia. Hodgkin's disease, they began to do these treatments at the NCI with a combination regimen they called MOP. But the most common cancer then and today in young men was testicular cancer. And although if it was caught early, you could cure about half of the patients, virtually everyone with advanced disease or those who were not cured with surgery died, usually within a year or so. A few months ago, we celebrated the 50th anniversary of the first patient who was treated with testis cancer, John Cleland, with platinum bleomycin by Larry Einhorn. And we had a big celebration in the university with Larry, and this is a before and after picture. In his earlier days, he looked a lot like Woody Allen. In his older days, he just looks like an old Woody Allen. But it was a wonderful celebration in which we brought in former patients, former fellows, and it was a remarkable deal. And just a little bit of a brief story about testis cancer for those not in oncology. This thing started, again, it was a horrible disease. There was a guy named Barnett Rosenberg who was up at Michigan State, and I'm one of our faculty here trained at Michigan State. Barnett Rosenberg did this crazy experiment with electrodes and electricity and E. coli. He had this bath, and it turned out around the anode, I believe, all the bacteria were dying. And I would have said, oh, that's kind of a neat little science experiment, but he took it another step and realized that it was probably the salts in the bath, and there were platinum salts because the anode was made out of platinum. And so he did work on this, and shortly thereafter came up with this drug, cis-diamine dichloroplatinem. And this was a drug that actually worked in vitro against cancer cells and in vivo. Another experiment was done in phase 1 at Roswell Park, in which there were 7 patients treated with refractory testis cancer, and several of them responded. So Larry Einhorn moved to Indiana University out of his fellowship at MD Anderson after a year, met up with John Donahue, who was in the far right. John was head of urology, who was seeing all these patients with testis cancer. And Larry came up with this crazy idea of putting together this drug platinum together with this Velban and bleomycin. And this was his original regimen here. And it was, again, for those not in oncology, please don't take notes. This is not important. But it was treated with 4 cycles of therapy and then maintenance therapy for 2 years, which is what we did for acute leukemia. Well, to summarize this, again, there's about 9,000 cases of testis cancer a day. It still is the most common kind of cancer. His work led to a 95% cure rate. There's no disease. Even pneumococcal pneumonia doesn't have this kind of cure rate in medicine. So he transformed this disease with his work. And in addition to that, he ended up doing a number of trials, or led a number of trials, which many of us participated in, and curtailed the treatment from 2 years down to just 8 to 9 weeks for most patients. It was really the beginning of what we saw as a successful model for cancer, but it was also the beginning of something we didn't talk about then, and that was pragmatic trials of really doing simple endpoints of looking at survival and looking at trying to truncate the therapy. And so we'll come back to that a little bit later on. So now, next chapter, cancer and the public health crisis. We've made great advances in cancer, and many of you know this, particularly with the onset of immunotherapy and many other therapies. This is incredibly expensive, and the cost of healthcare is going up dramatically. If we looked at the gross domestic product of many countries in the world, our healthcare budget ranks 5th among all the so we are really, really going crazy with this. As a result of this, even though that we are doing great things, the financial burden that we're placing on patients with cancer is enormous. This is from data from 10 years ago and has not gotten any better, that about 20% of patients between 19 and 64 struggle with paying their healthcare bills. It's estimated that nearly $100 billion was borrowed by the United States per year for debt. We also know, not shown on this slide, that those patients have a much higher likelihood of developing a bankruptcy. And as a result, those who have bankruptcy and other data have a worse prognosis than those that don't. And so because of the treatment that we give and the financial burden we put on patients, it's a little bit like giving lung cancer patients cigarettes, that we're causing this thing and actually shortening their life because of the burden we place financially. If we look at how we're doing and how is we're spending a lot of money on healthcare, so we ought to be one of the best. If we look at this In terms of all the other countries, the high-income countries in the world, we spend more than any other country in the world, and yet the mortality rate, which is above that blue line there, there's a dozen countries who do better than the United States. Even when we adjust for smoking, again, the United States spends a heck of a lot of money, and the outcomes are not quite as good. And so in terms of the public health crisis here in the United States, there is a lot of issues that we need to address. It's fiscal toxicities, it's access to care, it's cultural issues, ethics, health policy, that word I'm not supposed to use, survivorship, and prevention and treatment. And so at the intersection of cancer disparities and equity and culture is what I believe is global oncology. Specifically, if we look at low-income countries, low to middle-income countries, and cancer, 70% of the new cancers in the world are going to occur in the LMICs. This is a rate that's disproportionately higher than compared to the industrial countries like us. If we look at mortality rates by income group, you can, on the left column there is low income, and the right column is high income. In particular, if we focus on breast cancer and testis cancer, as I mentioned before, a 5% mortality rate in the United States. It's about a 40% in low-income countries. Breast cancer, similarly, across the board, there's about a 35% difference in terms of mortality just because of an accident of birth. If we specifically look at pediatric patients, and we've made great strides, and I think they have commercials for St. Jude here on TV, don't they? Yeah, they do. So 80% of the children in the United States will survive, all children with cancer. But if we look at those people who are in low-income country, 90% of them die. And so if you think about disparities between those populations, it's huge. And so it's hard, I think, as we think about this, and I think it's very easy for us in this room and those other places to say, this is crazy, that's just their problem. It's not ours. They don't have anything to do with what we do, that these issues are just worlds apart. But in reality, I'm not sure they are. And if we look at the social determinants of health in terms of financial toxicity, this is real in LMICs, it's absolutely real in this country. If we look at access to care, there are many people in this country who are in rural parts of the country and don't have access to outstanding care, just as they do in LMICs. We have cultural sensitivity, and we would have said, oh, this is no big deal. But all you have to do is just turn the news on every night and realize that there's a big chasm between different populations here in the United States. Similarly, in other countries, these chasms may be based on religion or tribal issues. The unique thing about Africa and the low MICs is that many of the cancers are not caused by tobacco, but are caused by viruses and other actions. These viruses come here. We have the same aspects of it. It gives us a chance to do some unique studying. And finally, the issues of genomics and pharmacogenomics, the differences of cancer and how they're caused, I think is a matter of deep exploration and translational research that affects all of us. This is a commentary that we wrote a few months ago for the AACI, the American Association of Cancer Institutes. And these were leaders from the United States. Satish Gopal is head of the Centers of Global Health for the NCI, and other people from Mexico and from Africa. And this gets to the title of my talk, and just to have the differences. A transaction, in terms of how we think about this, it might be, can you accrue patients to our clinical trial? We'll pay you. A collaboration is, okay, we want to go to Africa and we want to get all the breast tissue you have. You can bring it here and we'll do our genomic testing on that. And that's great. We may learn something from that. But what we really want to strive for is partnerships. And when we think about partnerships, it's really asking the question of each other, what are your issues? Here are my issues. And then finally, how can we solve our problems together? And this means it's a longer lasting relationship, and it gets us through the ups and downs of common times. So what I want to do now is talk a little bit about a partnership that we've done in Western Kenya, AMPATH. This was a gentleman, Joe Mamlin and Bob Einturns and Charlie Kelly started this program of AMPATH about 35 years ago. It was just an exchange of students going back and forth between Western Kenya. It was a fledgling medical school. Joe Mamlin, who was a former head of medicine at our county hospital, had retired and had moved there for a year just to help with teaching. And after rounds every day, he would notice that all the students went to this one bed where this gentleman was lying. And he finally said, "What's the deal here?" And it turned out that this was a medical student. It was a fellow medical student who was dying of AIDS. So Joe was moved. He called back to the United States. Charlie Kelly was able to get some antiretrovirals for him. And this is an updated picture of him. And it shows the vast improvement that was made with the use of antiretrovirals. This was the beginning of what they called the Academic Arm for the Prevention and Treatment of HIV. That's where AMPATH first got its words. And so they became this consortium, and they worked on constructing this work so they would be focused on dealing with the aspects of the HIV pandemic that was occurring in Kenya, one of the worst in the world. The AMPATH Consortium is an organizational construct between Moi University, which is it was a university in Western Kenya, Moi Teaching and Referral Hospital, which is their main hospital there, and we'll talk about that in a second, and a consortium of North American institutions led by Indiana University. This is, again, geographically, this gives you a little bit of background where Nairobi is. Eldoret is about 4.5 hours by car northwest of Nairobi. This is a list of many of the institutions that are part of this consortium. Again, this partnership of people working together. This is a picture of Moi Teaching and Referral Hospital. This is the second largest hospital and the second public teaching and referral hospital in Kenya. It serves Western Kenya, which has a catchment population of around 20 million people. It has a total bed count of 900 with a daily census of about 1,400. I'm going to pause there for a second. Okay. A bed 900 and a census of 1,400. What that means is that many of the patients are actually on the same bed. They're spooned together because of the shortages. And so they would stay there weeks or sometimes months at a time with not a roommate, but with a bedmate there of someone they didn't really know. They have a NICU, and we now have a children's hospital, and we have an ICU bed. So on the HIV side, there's been over 200,000 people that have HIV that have been enrolled on that. 85,000 of them are currently on antiretrovirals. Through the physical infrastructure has grown over the years. We have a mother and baby hospital. We have a pediatric hospital. Another pediatric cancer hospital is being built right now. And we built a Chandaria Cancer Center. I'll talk about that in a little bit. And we have institutional commitment. So on ground at all times are up to 20 to 30 people from North American institutions. There are residents, medical students, faculty who are on ground in various different specialties. And it really makes this a very dynamic partnership in which we're working hand in hand with the Kenyans. And I want to emphasize that this is a Kenyan-led program in which we serve as advisors. So let's turn to in my bailiwick, the AMPATH Oncology. And so about a little over 20 years ago, I took a visit there and I was just blown away. And what I saw was this transformation of what they were doing for HIV patients, but cancer patients were just shuttled to the back of the clinic and basically left to die. When we look at the world and we think about the number of physicians that we have, this is a cartoon drawing of the number of physicians per population. And so if you look at this, the United States looks a little bloated there. If you look at Africa, actually it looks like an appendix. And this speaks to the fact that the few number of physicians who are here to take care of patients there. India and China are a little bit more bloated too. So in terms of Africa, the current population is 1.3 billion people. It's estimated that there'll be about 2 billion people in 2038 and 2.5 billion by 2050. It has 16% of the world's population, but only 3% of the healthcare professionals. So if we flash to Kenya, this is about the time my first visit there in 2003, there was no cancer registry, no national screening program for breast or cervical cancer. They had 2 cobalt radiation units in the entire country. They were both in Nairobi. One of them was broken. The other one had a queue of around 4 months. They had 3 or 4 oncologists who were loosely trained in the country and about 4 radiation oncologists. This is an example at Moi Teaching Referral Hospital, the clinic in which chemotherapy was administered under a tent. It's hard to, I'm not sure if I can do this. Yeah, you can. If you look at here, actually, they would give the chemotherapy here, and after they're through, they would just throw it in this basket, the needles. I have no clue how they disposed of these needles afterwards, and I didn't ask. So let's flash forward now. In 2025, we now have the Chandaria Cancer and Chronic Care Center, and this was built through philanthropy from the School of Medicine, from one of the Eli Lilly heirs who wanted to be anonymous, and Chandaria, who is an Indian extraction African in Kenya who donated about $500,000 and was therefore named after him. Again, as we flash forward, this $5.5 million cancer building is now there. We have 2 linear accelerators. We have a chemotherapy infusion suite, which I'll show you in a second. Back when we started, there were about 150 cancer patients a year. We're now 150 cancer patients a day that are seen. 50 of them are receiving radiation therapy and about the same number with chemotherapy. We screen over 120,000 women for breast cancer, and we have we have a very strong faculty now of medical oncologists, pediatric oncologists, and gyne oncologists. We've established training programs in gyne oncology, the first in the country, nursing and pediatric oncology, medical oncology. We've developed training programs for palliative care, and we just recently started a pathology fellowship. We've had a couple of D43s for the Department of Medicine and Implementation Research. I'm co-PI of a U54. We are the lead institution for the East Africa IDEA Regional Consortium, and we've had a number of different supplements. We're one of the first 4 sites to be selected by the AIDS Malignancy Consortium to have a group outside of Africa. This is a picture of our infusion area, which is markedly different than the tent that I showed you before. I just wanted to give you a few highlights on a few diseases. Kaposi sarcoma, as you know, is closely associated with HIV. It's associated with this Kaposi sarcoma-associated herpes virus, or KSHV. It is an AIDS malignancy. It's an AIDS-defining malignancy. And despite the fact that here in the United States with antiretrovirals we see a markedly decreased incidence of this, this is still pretty profoundly common in Africa for some unknown reasons. The systemic therapy for this has been, here oftentimes we use Doxil for advanced disease. It's hard to get it, it's an expensive drug, and so we looked at other options. Eli Lilly, which is housed in Indiana, was very generous with giving insulin and also gemcitabine. And so Dr. Busakala, one of my colleagues, said, let's try it in Kaposi sarcoma. And so he did do a retrospective analysis, and they found some activity. Then he did a prospective study of looking at gemcitabine versus vinblastine and bleomycin. And basically what they found is that the response rate for this was really quite high. It was around 50 to 60% for gemcitabine. And as a result of this, the NCCN guidelines that we use in the United States has actually included now gemcitabine as one of the options for patients with recurrent disease. So this is a lesson in which research was done in Africa and has applications here in the United States. In terms of access to care, Burkitt's lymphoma was first described in the 1950s by Dr. Dennis Burkitt, who found this unusual pattern of tumors that were growing in young kids. This was eventually associated with the Epstein-Barr virus because samples from Africa were brought up to England to do this study. There has been much work that has been done around the globe, but ironically back in Africa where this started, the cure rate for Burkitt's lymphoma was only about 5 or 10%. And so even in Eldoret, when we looked at this, it was something that was quite sad. The picture on the top left is a real patient from Kenya that was a patient of Dr. Bob Einturns, who started the program. What we did was a simple thing. Everyone was getting the same therapy, but the problem was it was access to care. So patients would come in with their families, they may get one treatment, but they couldn't afford to travel 4.5, 5 hours back to the clinic. And so we got this supplement grant from the NCI of just giving the patients and their families a small stipend to cover for travel and food and for housing. And with that, we basically doubled the response rate or the cure rate for patients with Burkitt's just by doing this simple little maneuver. We were talking last night at WashU. This is an incredible place. But how many people see patients here? We got a lot. Okay. How many people have not had a patient complain about parking? Okay, yeah. So the simple fact, if we could just pay for their parking, it would really make their life a lot better. but I can imagine traveling 4.5 hours by a matatu and trying to get to this thing. So anyhow, this shows that just paying simple attention to this can make a difference. The other disease that's quite common in sub-Saharan Africa is cervical cancer. It's the #1 cause of death in most of the sub-Saharan African countries, cervical cancer. I suspect in Missouri there's probably 10 people that die of cervical cancer because of the screening that we do in HPV vaccinations. But this is the leading cause of death among men and women. Breast cancer is also up there in terms of #2. So these are very, very common. 70% of the diagnosis of HIV worldwide is found in Kenya and Uganda. And this is one of the AIDS-defining malignancies that are seen in which people have like a 50 to 100% chance of having greater chances of getting cervical cancer and dying from it in Africa compared to the United States. Eli Lilly helped sponsor a program we call the ABCCP, the AMPATH Breast and Cervical Cancer Control Program. We screened over 120,000 women. This is the largest co-screening program that we believe has happened anywhere in the world. And what we ended up doing, we found 715 patients with breast cancer and 416 patients with cervical cancer. Just in the last year alone, we've screened an additional 15,000 people. We've had 15 gyne-oncs graduated from our program in the meantime. So what we have done is actually impacted the country, not only by developing new physicians that can take care of them, but also by explaining to the women of Kenya the importance of screening, which is something that was really antithetical to their beliefs before this. And so this is really quite good. Next step, we've now developed a partnership with Nepal. It's called the Kenya-Nepal Oncology Network. It doesn't have that same ring as the hog, but it works. And our colleagues in Nepal are basically going to partner with us to do screening there. We were just there a few weeks ago, and I think I have a picture to show you in a minute. But again, basically what we're doing is trying to implore other means. Mammography is still quite difficult to have in sub-Saharan Africa. The equipment is not available in most sites, so we are relying on clinical exam. Visual inspection with acetic acid, where we paint the cervix with acetic acid, and if there's atypia or dysplasia, it'll whiten up. And these are the patients then who are treated either locally with cryotherapy, or they have a loop excision with electrotherapy or LEAP procedures to remove the tumors here. We're working on decreasing the follow-up there, and as we said, we're now developing this triangular partnership with Nepal and with Kenya. We were just here last month, May. Yeah, so a month ago I was there in Nepal with this group. We brought a group of people from Kenya together with the Nepalese doctors, and it was just an unbelievable experience there. But what they're doing there is really extraordinary. For those those involved in global oncology, and I'll talk a little bit more from an institutional point of view, this is not a humanitarian effort. This is really, when you think about the academic model, it's about research, it's about education, and it's about clinical care. And the glue that keeps us together with these is our research efforts here. And we've been fortunate that we have a diverse portfolio, I use the word again, of funding that have supported our work from industry as well as from the NIH and NCI, and we're so grateful for all of these for helping with support of this. This is just a random shots as a time. I just wanted to have a little spacer here of our folks that have been involved in Kenya. And I think what you might appreciate if you really look, with the exception of the people on the bottom right, these are incredibly happy people, okay? These are not poor, sad pictures that you see when you see it at 11 o'clock at night when you're along with the ASPCA dog pictures there. These are just happy people, and it's just a pure joy to work with them. So briefly to summarize what's happened over the last 20 years, again, in the early 2000s, there was one oncologist in AMPATH. We saw about 150 patients a year, no radiation therapy. I came back and met with a good friend of mine that I've known for my entire life, asked him for my ideas. He said, listen, I'll give you money for a year. And so we ended up getting this thing jump-started, and we were able to treat everyone who needed treatment with chemotherapy, the ability to give them chemotherapy. Whoops. We then built the Chandaria Cancer Center. We created a Department of Medical Oncology. We've developed these fellowship programs, and we have the first Linear Accelerator. We've had a couple of U54s, and now it's actually, it's quite exciting as we move on to our Kenyan partnership. All right, next chapter, partnerships and pragmatic trials. Washington University, as well as Indiana University, is part of a network of cancer centers, the NCI Designated Cancer Center Network. There are 72 of us. It's a very competitive process. WashU has been one of the most successful programs around the country. A few years ago, I was a consultant to the NCI and helped participate in this survey of cancer centers. And when we surveyed all of the cancer centers in the country, 91% of them were involved in global oncology in one way or the other. Some of them had a formal global oncology program. Some of them just had global activities. There's only a few, less than 10% of them that had nothing going on with global. The reality was that I think the cancer director didn't know that they had stuff going on globally, but it was really going on. Where did the money come from this? Most of the time it came from philanthropy. They may have startup funds, that may have been generosity from the cancer center directors. There was some international money that we have. Yeah, if I was tall enough, I could do it. So we have some grant funding that was there, but most of this, I think, was mission-based, that people felt it was important for the institution. There's a number of different exemplars of cancer centers that have been doing work globally, and I could spend an hour with each one of these centers, whether it's the Hutch working in Uganda, the Partners in Health that's working in Botswana and Haiti, the UCSF that's working in Tanzania, Botswana UPenn partnership, and the UNC who've been working with Malawi. But I thought I would just put one brief spotlight on what WashU is doing. And Thomas Odenye, who is up, Thomas is here, isn't he? No? There he is, Thomas. Hey, how are you? Hi, Thomas. Was recruited here a few years ago from the NCI. He finished his fellowship at the NCI, but had his PhD at University of Washington. And he is a native Kenyan and has moved back to help build the program there in Kisumu, which is a few hours away from where we are in Eldoret. He's developed this very unique dashboard, which I would love to have in Indiana, in which they can actually monitor disease and looking at the sites. And this allows them, and it would allow us in our state, to be more tactical in terms of what we're doing in terms of cancer screening and prevention, rather than just globally saying it's breast cancer day or it's colon cancer day. He's also looked at the social determinants of health and interaction of people living with AIDS. And so I think what I would suggest at some point, it would be great to have Thomas down here giving a talk about all the great things that they're doing there. But I think this is an example of what we're doing. Throughout the African continent, there are a number of different partnerships that are going on. To my disappointment, if you will, these are partnerships that oftentimes are one-off. So it's one institution working with another investigator, another institution. But what I would love to see is a partnership in which we have more coordinated efforts in North America, as well as more coordinated efforts in sub-Saharan Africa. In terms of clinical trials, this is the mainstay of what we do in oncology. Several years ago at ASCO, as on the board of directors, we were talking about the different talking points and the aims and the missions of it. And unlike any other discipline, we believe that in oncology, clinical trials is the standard of care. And until we can cure every patient with cancer, it remains that way. Unfortunately, when we think about clinical trials in Africa, we fall way short. Only 1.5% of all the clinical trials globally are conducted in Africa. And most of these, 90% of them, are done either up in Egypt or in South Africa. So we need to build up on this and build on this. Chris Booth, this is a little tilt to the idea of common sense oncology, and hopefully this will resonate with you, is that much of what we do in clinical trials today are looking at endpoints that are trying to get a drug marketed. So we may look at the disease-free interval, in which it may take 4 months to have a cancer come back as opposed to 1 month or 2 months. And this is not particularly meaningful, really, to patients. I've not yet had a patient come into me and say, how long is my disease-free interval going to be? What they care about is their survival, and they care about toxicity. So Chris put together this notion of common sense oncology, and it's really gaining momentum. And this Common Sense Oncology Initiative, and I'll read this, will undoubtedly evolve over time, but our core mission will continue to ensure that cancer care and innovation is focused on the outcomes that matter the most to patients rather than the commercial bottom line. Putting it a little bit differently, one of our fellows who will soon be a faculty member, Hussein Raganwala, just had this article published in the Journal of Global Oncology, is that if we need to think about our clinical trials with a pragmatic approach. We need to be thinking about this here as well as overseas and looking at trials that minimize the regulatory barriers, that minimize the patient-related barriers, and as well as reducing some of the provider-induced barriers. Looking at collaborative partnerships with each other and with industry, but most importantly, focusing on endpoints that are really unique to the region and important. So it's really overall survival. It's looking at clinical trials that are done cheaply and more efficiently. It is a crime today. Anybody doing clinical trials in cancer here? Okay, yeah. So I'll just tell you that, again, through the Hoosier Oncology Group, we had an institution several years ago who didn't want to participate in a trial that we've done because they were only getting $20,000 a patient to put on this clinical trial. This is unbelievable. We ought to be able to do simple pragmatic trials at endpoints for a fraction of that cost, and we need to get back to doing that. We tend to collect all of this massive amount of data, but yet when the publication comes out, we don't even include the data in there. A couple examples of pragmatic trials. This one was just published a few months ago about the yellow fever vaccine. Simple design. It was a double-blind randomized trial that was done in Uganda and Kenya, and it really looked at basically seeing whether or not these people needed a high dose, standard dose of 13,000 units, or they could use lower dosages. And what they basically found is that at the lower dosages, they had just as good of an effect as they did at the higher dosages. A simple pragmatic stuff. If you could do this, this means that 2 or 3 or 4 people could get vaccinated with the same amount of vaccine than you did for one person. Similarly, the same thing's true with HPV vaccination. So typically, when it first came out, it said that we needed to do 3 vaccines for everyone. 2 has become the standard in terms of vaccines. And then work done in Costa Rica and in Africa have shown actually that just 1 vaccine is sufficient to give you protection. Again, with the cost of vaccine being prohibitive in low-income countries, the opportunity to actually vaccinate 3 people instead of 1 is huge. So, oops. This is crazy. There we go. So the last thing is this perchance a dream. So Bob Einturns, who was one of the founders of AMPATH and a good friend of mine, had this quote. So I'm just going to finish up with a couple different quotes and a random thought. So he said, basically, if we can create the space to dream, to risk, to fail, and dream again, if we can do that collaboratively, where no one's ego is on the line, we might just be able to change the world for the better. So I think in terms of my thoughts about my dream, in terms of what we can do, I would really love for us to have an increased and enhanced training for global oncology workforce so that we could help deal with the deficits that are seen around the globe. I would really love to see us build the clinical and translational research capacity by doing contextually important research trials that include the social determinants of health, that includes implementation research, and includes pragmatic trials. I think it is an opportunity for us to look at the unique genomics and pharmacogenomics that are seen in other parts of the world to see how they handle drugs. One trial, which I didn't talk about, vincristine, which is a commonly used drug, it turns out it's metabolized quite differently in African Americans and in Africans compared to Caucasians. So that the same dose of vincristine is metabolized so that they have less therapeutic value and they have less neuropathy. And so a simple trial basically is to escalate the dose of vincristine in this population that may improve the cure rate. And then look at basically other colleagues and instead of just having a device like an iPhone or even the microphone, is really embedding engineers into the LMICs, having them work with the people there, but have develop social justice engineering in which we can develop products not that cost a lot of money, but how you can actually deliver care and deliver communications and technology at a much more cheaper rate. We need to focus on prevention and early detection rather than treatment, which is what we do in this country, unfortunately, which is part of the problem of the escalation of cost. I would love for us to develop a cooperative group like we have here in the United States with many different universities working together to do clinical trials, but to have many institutions in Latin America and South America and Africa working together to develop clinical trials that they design that are applicable to them, and they lead, they present at national meetings. I would also like for us to optimize our collaborations here in North America. So it's not just one institution working with another one over there, but rather all of us collectively learning from each other, sharing our curriculum, sharing the ideas of clinical trials, and working together to make the world a better place. And finally, again, the final dream is to see if we can make universal healthcare coverage a reality. I'm going to close by just asking this question, why? Now, as I was thinking about this slide, I was thinking, okay, there's a lot, you guys are sitting there saying, why did I come to this lecture? And why did we invite him? But I think one of the questions that often comes up in terms of why should we be doing work around the world when we have problems here in our own hometown? This is a quote I think is just brilliant from Paul Farmer, who is the founder of Partners in Health, who unfortunately passed away a few years ago. He had done this seminal work in Haiti and in Botswana, mostly focused on HIV. But I think he summed it up better than anybody else by saying this. He said, "The idea that some lives matter less is the root of all that's wrong in the world." So we close. I'm going to close with, again, an assignment. The CME folks, I don't know if you guys have given talks, they give you these requirements, and you're supposed to put these closing comments and then action items for all of you. And so the closing comments is just kind of a review of things, of thinking right now about this guy, Larry Einhorn, who, when he started 50 years ago, had no idea that what he would do would impact the field of oncology and the cure rate. He didn't know that John Cleland, who was was just a student at Purdue, would become a science teacher in Zionsville and impact thousands of students around the world. George Carlin just was a comic, a stand-up comic for Pete's sake, and wanted to make a living doing that. But he ended up, having this tied in with the 7 words that you couldn't say, and it had so he was actually a model of impacting the freedom of speech. And then finally, Gustav Schoenfeld. And I think he's a man, again, I don't know. I didn't know him. I know Dr. Fraser knew him. He made a huge impact in terms of what he wrote, not only what he did in medicine, but also what is explaining his story of his growing up in Nazi Germany and surviving Auschwitz. These men, had an impact. And so my charge to you guys tonight, I want you to lay down in bed, think a little bit about these people, and then reflect 50 years from now, looking back at all that you have done over the last 50 years. What do you think your impact will be? And what should it be? And then close your eyes and go to sleep. Thank you. I'm supposed to show this CME stuff. And then if you want to look at the slides, that's the summary stuff, but I didn't show that. I'm passive aggressive. Thank you.
What an inspiring body of work, how inspiring the whole thing is. You are incredible. What you're doing is amazing. I have several questions, but I won't start off. We'll start off with the audience.
Yes.
Great talk. I was wondering, I've heard Roy Badgett talk about ivermectin in Africa and how that was kind of a lever for diplomacy. And you talked about the why for empath being research and clinical care. But I was wondering if diplomacy also factors in the empath mission and what your experiences have been on that.
Yes.
Pat, before you answer, my charge is I always follow the directives of my chair. She told me to repeat the question, so I'm going to repeat it. So the question is diplomacy in global affairs. And perhaps illustrative example, ivermectin.
Man, that last one, the ivermectin part I didn't hear very well, and I'm not going to hear that part. But it is a charge issue. Again, as we think about global health, we have, as we said, we have research, we have education, we have clinical care, and I think health policy is an important part of global health. It's a unique thing. It ought to be part of our efforts here of how can we bring other agencies together to help survive. So I think health policy, if we're going to do a truly good global health program, it's not just about what we're doing overseas, it's what we're doing here. So this health policy and working with government, working with agencies to come up with stuff. I'm an agnostic on ivermectin. I think in terms of it being something that can pull people together. I just had a patient on Monday who has advanced colon cancer, and she wants to do ivermectin instead of Folfox. And I had to have a 2-hour conversation.
Just to clarify,
Yes.
so Roy Vangelos was the head of chemistry here, and
Yes.
he was the head of Merck. He donated ivermectin to eradicate river blindness
Oh, okay.
around the world without board approval. So his board said absolutely not, he did it anyway, and made this, huge, very positive impact for that particular disease.
Love it.
There's all the more creative thoughts about ivermectin.
Thank you. Yeah. I'm not sure if I told you that I love you, but thank you for answering that question, because I was going in a completely different area with ivermectin. So, yeah. So thank you for clarifying that. Yeah. So that's a big deal. So Lilly's been incredibly generous in giving insulin and dealing with ivermectin. So those kinds of things are worthwhile. I think trying to work with companies to try to get drugs at a cheaper cost, whether it's vaccines, whether it's dealing with ivermectin or many of the other chronic diseases, worthwhile. But I think that's part of the fun about doing this, is that people who are involved in global health are looking at innovative ways and innovative partners to do that. But thank you for getting me out of this hole here, because I was going in a completely different way with ivermectin.
Thank you.
Yeah, thank you.
Amanda?
Thank you for the terrific, inspiring talk. You mentioned the HPV vaccine briefly, but hearing about the huge impact of cervical cancer in many of these African countries, certainly it seems like getting the HPV vaccine to more people could be a really important way to prevent many cancers. So is that part of the work you've done, or have you found barriers to the vaccine approach?
Yeah, the big barrier is cost. And so the average income in Kenya is something like $50 to $100 annual income. And the vaccine may cost $20 to $50 depending on what's going on. And so for a disease that you're trying to prevent as opposed to something that you're treating. So we've got to figure out a way to lower the cost, and that's why doing one vaccine versus 2 or 3 makes a huge difference. We've got to work with companies, and more likely than not, it'll probably come out of India, where they can develop drugs cheaper and generically that will come into effect. But absolutely. Interestingly, I'm not sure what the HPV vaccination rate here is in Missouri. In Indiana, it's not great. In Nepal, which is one of the poorest countries in the world, any estimates of the vaccination rate, HPV vaccination rates among young kids? 95%. Unbelievable. So it absolutely can be done in low-income countries. And so we have to learn what we've done in Nepal and translate that to Kenya and also translate it here. But it's absolutely very important. This is like Tessa's again, we could eradicate this disease if we just getting these vaccinations out. Other questions?
I have one question, a comment and a question, Pat. I think you put this in one of your slides. It's not the question of how can we help you, or how can we get some samples from you. It's a bidirectional partnership. And one of the things that actually may be very relevant today is some of the drug doses are chosen arbitrarily in the US, or at least in the Western construct, the way it's all done. The great example is checkpoint blockade. I think we probably can get away with much less reduced dose than what it's been approved for, and there have been some promising results from India, for example, and precisely for the same reason you said. So I think the idea is to promote it's a bidirectional thing, and we can learn the lessons from there and incorporate that. And I just want to get your thoughts on the U.S. cooperative groups that do cancer research are really finding their new niche these days, because it's hard to do clinical trials with the U.S. cooperative group setting these days. This is where I think there's a great opportunity to partner with these, outside institutions, particularly Africa and the low middle income countries. I just want to know what can we do to make that process smoother and better.
It's an excellent point. I'm just going to go back 40 years ago when we started the Hoosier Oncology group. We had, there's a Platinum, which is a common drug, had an agreement to extend their patent life if they did money for research. And so the beginning of the HOG came with a trial we did in lung cancer with Platinum and vinblastine, I think, and we got $1,000 from Bristol Myers to do this. We went to the HOG and we created 3 trials, and our docs were willing to take $300 a patient for a clinical trial, and the $100 we put in a piggy bank for the rest of the group. So back then, it just had a data sheet with just 2 pages that had the response rate, survival, and then the major toxicities. And we're able to do this for many, many years. Now, as I said, it's so expensive. It is not, the problem is that we are all conflicted. We doctors think we work hard and we need to get as much money as we can. We do these RVUs. The drug companies say, listen, we've got our investors, and so we have to charge as much money as we can to get these drugs. There was, as I was driving here from Indianapolis, Fresh Air had an episode yesterday talking about this, a reporter who, he himself had myeloma and did some work on Revlimid, which was it's a derivative of thalidomide. It cost 25 cents a pill to make this. And they charge, when it first came out of the blocks, for about $55,000 a year. And when the company was losing money, they just ramped up the cost of Revlimid. And so I think there's a conflict with industry who want to make as much money as they can, and they feel they need to do this for their shareholders. I think we have to have this social construct in health policy of trying to figure out a way. Listen, there's something bigger than this. It's about the lives of people, and we need to be creative about doing it. Now, I did have a few slides. I agree with you. I think the immunotherapy, I didn't do it because this was medicine grand rounds rather than oncology. But absolutely, when the companies come out, they want to have the drug approved for the highest dosage and for the longest period of time. It's not their interest to take therapy for 2 years down to 9 weeks, like Dr. Einhorn did. And so, but it's up to us to do this. And so and those are going to be done in the NCI. It's going to be in these cooperative groups. It's not going to be an industry-sponsored trial in which they're going to look at their drug at standard doses and looking at a fraction of the dose. They aren't going to do that trial. And so we've got to have other mechanisms to do these trials. And I do think that the LMICs are poised to do these. It's in their interest, and it's in our interest for them to do those trials. Long-winded answer.
Absolutely. Good, Pat. Thanks so much for your great lecture, great work. Thank you again, everyone, for coming.
Tried.
Thank you so much. What a great.
Thanks for the kind introduction. Thanks for bailing me out.
Let's get you off.
Okay.